Imagine a disease so silent that millions live with it for years without even knowing it exists inside their bodies. Unlike many illnesses that announce their arrival dramatically, diabetes often creeps in quietly. By the time it is detected, the damage may already have begun, affecting the heart, kidneys, eyes, nerves, and blood vessels. Left unmanaged, the consequences can be devastating. But science at its best has the extraordinary ability to illuminate the unseen. Our story begins in 1968. An Iranian Jewish scientist, Samuel Rahbar, made a remarkable discovery. He found that excess sugar circulating in the bloodstream had a special affinity for a particular form of hemoglobin found in the red blood cells, what we now know as the HbA1c. A few years later, in 1976, American scientist Anthony Cerami and his colleagues transformed this scientific insight into a practical diagnostic tool, the HbA1c test. Suddenly, physicians had a powerful new weapon. They could now measure long-term blood sugar levels and identify people living with diabetes, often before the serious complications developed. It was a triumph of medical science. Yet, as history repeatedly shows us, discovering something is one thing. Deciding how that discovery is applied to millions of people is something else entirely. And that brings us to this episode of globalheadwinds.com. Today we ask a question that may sound controversial, but is worth examining. Detecting diabetes is undoubtedly a medical breakthrough, but who decides what constitutes normal blood sugar in the first place? Globally, the medical community largely follows standards recommended by organizations such as the American Diabetes Association or the ADA and the World Health Organization, and understandably so. Medicine requires benchmarks, doctors need reference points, patients need clarity. Someone has to define where the normal ends and the disease begins. For adults, fasting blood sugar levels are generally considered normal when they lie between 70 and 99 milligrams per deciliter. 2 hours after a meal, blood glucose is typically expected to remain below 140 milligrams per deciliter. Cross these thresholds and further evaluation becomes necessary. So far, everything appears straightforward, but the discussion became more interesting in the late 1990s. In 1997, the American Diabetes Association proposed that diabetes be diagnosed when fasting plasma glucose reached 126 milligrams per deciliter. The World Health Organization adopted a similar recommendation in 1999. From a public health perspective, the rationale was clear: identify people earlier, intervene sooner, and prevent complications. After all, early detection saves lives. However, medical science rarely deals in absolute certainties. Many clinical guidelines emerge from studies involving hundreds of thousands of patients. Researchers analyze patterns, probabilities, and statistical associations. Then they generalize these findings to entire populations. Given the global scale of diabetes, some degree of generalization is inevitable. But whenever a small group of experts establishes standards that influence billions of people, questions naturally arise. One such question concerns the concept of prediabetes. The introduction of this category suggested that individuals with blood sugar levels above normal but below the diabetic range were at increased risk of developing diabetes in the future. The intention was preventive, encourage lifestyle changes before full-blown disease develops. And few would argue against the healthier diets, regular exercise, or weight management. Yet critics ask, does categorizing large number of people as pre-diabetic also have unintended consequences? Disease management often extends beyond lifestyle advice. It may eventually involve regular monitoring, repeated consultations, and in some cases, lifelong medication. And where long-term medication is involved, economics inevitably enters the conversation. Who benefits when millions more people are identified as requiring ongoing management? Patients may benefit through early intervention, doctors may benefit by preventing complications. But pharmaceutical companies also stand to gain from expanded markets. This is where the debate becomes particularly contentious. Over the years, concerns have been raised about the financial relationships between pharmaceutical companies and medical organizations, including research funding, grants, and sponsorships. And the American Diabetic Association is no exception. To be clear, industry funding does not automatically invalidate scientific research. Much of the modern medical progress has been made possible through collaboration between academia, healthcare institutions, and industry. Nevertheless, critics argue that financial ties can create perceptions of conflict of interest. Did the creation of prediabetes arise solely from scientific evidence? Or did commercial considerations consciously or unconsciously also influence the process? These questions seem subjects of ongoing debate. Supporters of existing guidelines argue that millions of people have benefited from earlier diagnosis and intervention. Skeptics countered that expanding diagnostic categories risk medicalizing otherwise healthy individuals and may contribute to unnecessary treatment. Perhaps the real issue is larger than diabetes itself. It concerns the complex relationship between the medical science, public health policy, and the pharmaceutical industry. Where should the line be drawn between the prevention and overdiagnosis? How transparent should medical organizations be about funding sources? And how do we ensure that the scientific guidelines serve patients first and commercial interests second? These are difficult questions, but in a world where medical recommendations shapes the lives of billions, they are questions worth asking.